Thank you for coming this evening. And I need to show my disclosures for research funding. We've had funding from our National Research Institute, the Institute of Health Research, from the NIH, Alzheimer's Society of Canada, Physician Services Incorporated, and Lawson Health Research, our local research foundation. I've also been a consultant to the pharmaceutical companies listed there in designing clinical trials. And we've also, our group has received over the last 25 years funding from all of those companies as well as the ones listed on the right-hand side of the screen. So if I'm contaminated, I'm equally contaminated by all of them. There are no favorites there. But we do work for the pharma-sponsored studies with pharmaceutical companies. That's necessary. But we also do a lot of investigator-initiated studies, observational studies as well, funded by the other agencies that we work with. So we're going to use the live polling tonight, and we're going to use an application called Meeting Pulse. So this is a bit of an experiment. This is the first time we've done this, and so it's going to be a bit of a cognitive test for me and my colleague Dana, who's going to be helping with the polling. I will cue you when the poll is ready, and hopefully for those of you who want to participate using your phones or your devices to be able to participate, you can do it. And what we'll do during the course of the evening is estimate where you are on the spectrum of cognitive decline, identify what your risk factors might be for cognitive decline in the future, project where you might be in the future, in particular 20 years out, reflect on what you're doing now to reduce your risk and improve your brain function. And then later on, after we've discussed some of the strategies and risk factors, to consider what additional strategies that you're not doing now that you may want to add. And lastly, to evaluate your interest in cognitive research. Some of you may recognize this as the Montreal Cognitive Assessment. So this is an instrument which was a Canadian devised instrument in Montreal and has had a lot of traction around the world. It's a screening instrument, and it doesn't make a diagnosis of dementia, but it's very useful in a number of different settings: family physicians, family health teams, primary care memory clinics, our own Aging Brain and Memory Clinic. We use it on inpatient services, on the consultation service in the hospitals, on our rehabilitation units. And so this gives us a measure. It just gives us a measure of where a person might be from time to time, particularly if they're having delirium or if they actually have a progressive disorder such as dementia. So you can see there's some animals, and we get them to name the animals. In that blank space, we draw a clock. There's a cube copy. There's the first part of what we call the trails B, alternating from a number to a letter to a number. Then there are 5 words across the bottom, and these are 5 words that I will say in the clinic to the person that I'm testing, and then I'm going to ask them to say the words back to me. So the 5 words are face, velvet, church, daisy, red. Okay, you got the idea. Okay, so we do that twice, and we're going to do it again. So I'm going to say the words again: face, velvet, church, daisy, red.
Face, velvet, church, daisy, red.
Okay, that's really good. So we're going to just reflect on those, and normally in the clinic I would ask people to remember those words, and then we would go on and do the other components of the test. There are 8 different elements of this test. We would look at tests of attention, tests of language, abstraction. We would ask some words about orientation. We would eventually come back to those 5 words again. Now, this is the spectrum of cognitive decline that we use in the Aging Brain and Memory Clinic. And so there are people who have what we refer to as being supernormal. These are people over 80 who score the same as 20-year-olds on memory tests, on detailed memory tests. This is an uncommon group of older people. Then there are people in their 50s, 60s, 70s, 80s who have what we regard as normal age-associated loss. memory and cognitive functions start to change in about the 40s in a very subtle way, but then continue after that. Subjective, now those people when they do the mini-mental state, or in particular the Montreal Cognitive Assessment, when they do that particular test, they score better than, or 26 or better on the MoCA test. Now, there are certain caveats about using a cut point on a test. Now, some people may do better on the test than 26, may score up to 30. It depends a bit on the educational level, and some people may score below. But as a general rule, 26 is the cut point that we regard as normal. But a person with a low level of education may not do quite as well. And the other caveat on the test is that the first time that you do the test, a person who's not familiar with it may not do very well, but on a second occasion may do better. So there are some caveats about this test that we have to be cautious about how we interpret them. Certainly doing the test repeatedly over time can be a very valuable exercise and important information on knowing whether a person is improving, staying the same, or getting worse. Now, people who have subjective cognitive decline are people who say that there has been a change in their memory. Their memory has changed. Usually it's their memory. It can be language. It can be another cognitive function, but often it's memory. And the second thing that they've noticed is they're concerned about it. Others around them may not be aware of it, but when they do the MoCA, they score 26 or better. People with mild cognitive impairment are people who clearly have changes in their memory, or maybe language, and they will score less than 26 on the MoCA. Their activities of daily living, their instrumental activities of daily living, are entirely normal. They may be a bit slower at doing things, but their instrumental activities of daily living are entirely normal. So those things like grocery shopping, cooking, yard work, housework, finances, to the extent that a person did those things. Dementia, on the other hand, are people who have cognitive impairment, and on whatever measure you tend to use to measure, particularly the MoCA, but other instruments we use as well. And also, their instrumental activities of daily living, one or more of those instrumental activities of daily living are significantly impaired. Now, to make that judgment, we have to talk to family members to get that information. We usually talk to family members separately to try and determine if that instrumental activity of daily living has changed. And when we see families over time, we will talk to them separately and see whether there's been any change, if there's been impairment on the instrumental activities of daily living. Now, across the bottom, you can see if we looked at people in Canada today, so these are people here 65 and over, 8% have dementia, 17% have mild cognitive impairment, and the other 75% would fall into a normal range. That's 85 and over. 1/3 have dementia, 1/3 have mild cognitive impairment, and 1/3 will be in the normal range. Prodromal dementia is that phase between mild cognitive and dementia. It's the prodrome before we get to dementia, and then dementia can obviously progress to mild, moderate, severe, or advanced. And as it progresses to the right there's increasing dependence in those instrumental activities of daily living. And then eventually, self-care activities of daily living, so dressing, bathing, eating, grooming, those things may become impaired. As well, there may be increasing behavioral changes and psychological symptoms that occur with dementia. Okay, so all together. Oh, you're pretty good. I don't think any of you need to be here, but we'll go on. That's good. Okay, so now, having reflected on the spectrum of cognitive decline, this is where we're going to start our first poll. And what we're going to ask you is to look at the spectrum of cognitive decline and determine where on that spectrum of cognitive decline that you think you are. So are you 1 if you're supernormal, 2 if you're normal, 3 subjective cognitive decline, 4 mild cognitive impairment, 5 dementia. You can't be more than one option. So is anyone still trying to decide where they are? Okay, I think what we'll do is we're going to close the poll. That's very interesting. So most of you in the age-consistent loss, and we have some people who are supernormal. Now, I was looking at the group before, and I didn't think there was anyone here who was over the age of 80. So I didn't think that was going to be possible, but maybe there are. So that's excellent. Okay, so we need to look at risk factors for dementia. So age, as you might have guessed, is the most important risk factor. The next risk factor we need to consider is a genetic risk factor, the most common genetic risk factors. There are several, but the most common one we talk about is the ApoE gene, and ApoE comes in 3 alleles, or types, if you like, ApoE2, ApoE3, ApoE4. And you get 1 gene from each of your parents, and if you happen to get 1 or 2 copies of ApoE4, you are at increased risk of developing Alzheimer's disease. And I'll explain later why that might be. Family history is tied into that. There may be other factors as well. Down syndrome is also a risk factor, and I'll also explain why that is later. Now, there are some risk factors that we can change. Inactivity, mild obesity, midlife obesity, high blood pressure, cholesterol, diabetes, smoking, major depressive disorders, low level of education, head injuries. So those are things that we can try and prevent or change. If we look at the cumulative risk, and we just look at risk of age alone, at age 60, the risk of having dementia would be about 1%. At age 90, that risk could be as much as 64%. If we add 1 risk factor, there's a doubling of that risk factor. And if we add 2 risk factors in addition to age, we're adding a further doubling of the risk factors. So now a person with 2 risk factors, and at age 80, they would have a risk of having dementia of about 64% on chance. So given that, thinking about those risk factors, where do you think you might be? So we're going to open your apps again. So we're going to look at the app again. Where on that spectrum of cognitive decline do you think you're going to be? So there's some discussion. Some people are not sure where they're going to be. And what you'll see here, that's interesting, but there has been a shift to the left. So people are thinking they're shifting to the right, moving in that direction of the spectrum of cognitive decline. So I think you've certainly got an idea of what the spectrum of cognitive decline means, and also what your particular risks might be. So now there are ways that we're going to try and reduce those risk factors. So there are 6 non-drug strategies to reduce the risk of cognitive decline. So regular aerobic resistive weight exercises, adherence to a Mediterranean-style diet, and I'm going to speak about each of those in more detail with looking at a little bit of the evidence. Mental stimulation, so finding new and interesting ways to stimulate the brain, to challenge the brain. Socialization, to be socially engaged, not to be isolated. Restorative sleep, so at least 7 or 8 hours of sleep, and it needs to be fitful sleep, and avoid things like sleep apnea. Reduction and cessation of alcohol. Certainly if a person already has some cognitive impairment, we strongly recommend that they reduce alcohol and even consider complete cessation. And there are very available now non-alcohol beers. I understand that there are non-alcohol wines. Some people don't care for them, but they are worth at least looking at if you need to reduce alcohol or even try and stop altogether. And in terms of psychoactive drugs, a common anticholinergic drug that people do use, we certainly see people in the clinic who take Gravol for sleep. Now, Gravol is a strongly anticholinergic agent. It opposes acetylcholine in the brain, and we see people who come in with cognitive impairment, they stop the Gravol, and within 2 or 3 months there's improved cognition. So it's something to think about in terms of looking carefully at the drugs. Recreational drugs, we don't know what's going to happen with marijuana in the future, but that's something where there's obviously going to be some research to look at that. Now, exercise in cross-sectional studies, we know that this improves brain health, it improves heart health, but if we look at longitudinal prospective studies, so these are longer studies of physical activity and prevention of Alzheimer's disease, so these are 9 large studies involving over 20,000 participants over the age of 65 who are free of dementia at the beginning of the study, and there's a definite reduced risk of Alzheimer's disease. And for those of you who are statistically inclined, this would be a fixed effects ratio of 0.61. We have studied exercise in many different ways, but one way I want to share with you tonight is the changes that you might see on a brain image, such as an MRI scan. We do a lot of MRI imaging here in London at the Robots Research Institute and at the Grosvenor site here. We have MRI scanners as well as part of some of the research studies that we do. And with physical exercise, you see greater grey matter. Grey matter is the part of the brain that does the thinking in the brain, and also there's a larger size of the hippocampus. The hippocampus is what we refer to as the memory department. As well, physical activity in people who already have dementia, so they've already got cognitive impairment. There's 18 randomized controlled trials there, and when you push those studies together in what's called a meta-analysis, you get a positive overall effect on cognitive function, particularly with interventions that involve aerobic exercise. And it doesn't matter so much the frequency, it's the fact that you're doing something, whether it's a high or low frequency, it's beneficial. We try to get at least 3 times per week, 30 minutes at a time as a minimum. Walking is very good. In this image here is a person with dementia with their caregiver walking. And this is the sort of thing that we want to encourage people to be able to continue to be exercise and to be stimulated and to socialize in this way. There is a video if you want to look more about some of the evidence in a very brief whiteboard presentation by Dr. Mike Evans from the Health Design Lab. This is really useful to look at. It's called 23 and a half hours. He's talking about the 23 and a half hours during the day where you're doing everything else but exercise, and then 30 minutes a day doing exercise. And he presents this in a very convincing way. So I'd encourage you to look at that. Diet is important. The Mediterranean-style diet it's a pyramid. We certainly want people eating a lot of vegetables and leafy greens, high-colored fruits, and whole grains for carbohydrates, dairy, in moderation, certainly olive oil and nuts, some high-fat dairy. Certainly the fish is an important component of the Mediterranean-style diet. So tuna, salmon, sardines, anchovies, herring. Not everyone likes all of those things, but certainly most people will eat tuna, and salmon, and sometimes if they don't even like that, eating fish would be as good as well. This is the Mediterranean-style diet, the analyses of 13 out of 18 longitudinal and prospective studies. So these are not just cross-sectional studies, these are studies over long periods of time where they've followed people and looked at what the outcomes are. So higher adherence to a Mediterranean-style diet either slows the rate of cognitive decline or minimizes the conversion to Alzheimer's disease and will improve cognitive function. There are future studies that are still going on that we want to get an idea, where can we have the greatest impact on late life cognition? Does the diet have to change in midlife? Does it have to change even earlier? Is it sufficient to start eating a Mediterranean-style diet in later life? What are the important components that provide that neuroprotection? Fish is certainly felt to be an important factor. There was a Swedish study in this analysis which did not show an effect of the Mediterranean-style diet. However, what it did show was increased meat consumption was associated with the increased risk of dementia and a lower brain volume, so the brain was not as large. So we see different effects from some of these different studies. This is the combination of looking at both diet and exercise. So you can see across The baseline here, this is over many years, 12 years, this is done in New York, and this is the probability of remaining Alzheimer's disease free. And I want to highlight just two groups, those with very high physical activity and the group that had very high diet score on the Mediterranean diet, the score used to score the Mediterranean style diet. And then those with a low physical activity and those with a low diet score. And so this group has progressed. Some have progressed to dementia, maybe 20%, but in this group, almost half have progressed to dementia. So this is a longitudinal observation study looking at exercise and diet and then breaking the groups up into these different combinations. Another multi-domain study, so this is going even further. This was a planned study, the finger study in Finland, 2 years, people at risk over the age of 60 to 77, and for those in the intervention group, so they were randomly assigned to the intervention group. They got instruction on nutrition, they were given a physical exercise program, cognitive training, and they addressed their vascular risk factors, and they were compared to a control group who got health advice alone. If they had vascular risk factors, they were given education about that as well. And the outcomes were improved cognition and reduced risk of cognitive decline for the intervention group. So this is a study that's ongoing, and there will be some further outcomes from this finger study. But this is a very important landmark study. And what it's telling us here is that it's not just going to be a single intervention, that it may be, in fact, a combination of interventions that is going to be even more powerful than just doing exercise or diet. I mentioned earlier there was mental stimulation, socialization, restorative sleep, B vitamins in people with mild cognitive impairment. If they have high homocysteine levels in their blood, may be a benefit. And for the chocolate lovers in the room, the good news, dark chocolate is good. We want to reduce as well other risk factors, and this is risk factors of other medical conditions which might cause clinical strokes or silent strokes. So we know that strokes are conditions that affect brain function and can certainly affect cognitive function. And you can have silent strokes. People can not be even bigger. So people are quite surprised when we show the MRI scans, we pull them up in the clinic, we look at the image, and they see holes in their brain. And they said, how is it possible that I've had strokes and I didn't even know about it? These are silent strokes, and they can occur particularly in people with these these vascular risk factors, high blood pressure. And these are some of the strategies to control the blood pressure, standing blood pressure, using home blood pressure recordings, controlling diabetes with home monitoring, and the hemoglobin A1C, which is the blood test, which is done every 3 months or so to see that the diabetes is well controlled. Managing elevated cholesterol, stopping smoking, and addressing atrial fibrillation. And for some people, coated aspirin may be appropriate as well. So these are the vascular risk factors that people need to address, in addition using the non-drug approaches for reducing the risk of cognitive impairment. So we're going to come to our next poll, and this one gets a little more complex. You're actually allowed, so if you open up your apps again, you're allowed to make a choice of several choices of these different interventions. We'll show those interventions again in a minute. So what are you doing now to reduce your risk? So you may not be doing anything, but some of you will be doing exercise, Mediterranean style diet, restorative sleep, mental stimulation, socialization, alcohol reduction, and if you have any of those vascular risk factors, you may be controlling those. So you can put any of those options in there into your apps. So I think everyone's put those in, and we'll see what people are doing to actually control the risk factors. So I'm glad virtually everyone is doing something, and you can see where it actually falls. This is what people are doing. So it looks like most people are exercising. That's good. That's the single most important thing you could be doing is exercise, mental stimulation, and socialization. It also gets a lot of support along with the Mediterranean style diet, restorative sleep, and control of vascular risk factors. So we'll go on and talk about some of the types of dementia. Alzheimer's, I've mentioned briefly. This is the most common form of dementia. The second most common form of dementia is vascular dementia due to those strokes or silent strokes or a combination of them. And vascular dementia and Alzheimer's disease, particularly in the people in their 80s and 90s, if they have vascular risk factors, often may be combined. So people may have both types of dementia. Some of you may have heard of Lewy body dementia, which is a dementia that often is overlaid on Alzheimer's disease. So it's part of that mixed dementia. So you can have Alzheimer's and vascular dementia as a mixed dementia, but you could have Lewy body in there as well. Sometimes, occasionally, you have Lewy body by itself, and it's characterized by visual hallucinations, Parkinsonism, and fluctuations in levels of consciousness. Restless legs can also be part of that picture. Frontotemporal dementia is much less common. And it tends to occur in people at a younger age, often between the ages of 50 and 70. If we look at Alzheimer's disease, Alzheimer described plaques and tangles. Those were the things that you'll have heard about, and he described that over 100 years ago. And the plaques are those brown patches on the left side of on the right side of the screen. And this is in the cytoplasm, and this is clusters of what we now know to be amyloid protein. And I'll talk a bit more about amyloid protein. We all have amyloid protein in our brain. This is an abnormal aggregation of amyloid protein, which clusters together as misfolded proteins and is deposited in the brain. And people who have the ApoE4 gene, 1 or 2 copies, are much more likely to have this amyloid protein accumulate in their brain. And part of the problem is they don't make more amyloid protein than anyone else. They just don't get rid of it as well as people. Exercise may moderate that. There is some evidence that exercise might actually help reduce that accumulation. After amyloid starts to deposit in the brain over a number of years, the next change that occurs is the tangles, the neurofibrillary tangles, and this is caused by a different type of protein called tau protein, TAU. And this protein is another misfolded protein, and it accumulates in the nerve cells. And you can see on the right there, the nerve cells there look different from the ones on the left, which are normal, and these are altered, and then eventually these nerve cells die. Now, there is a model to actually describe what we think is going on here, and I'll try and work through this. This is timeline in years, cognitively normal, people with mild cognitive, people with dementia. And this is the degree to which the biomarker that we're looking at changes. So amyloid protein I talked about, and it's accumulating in the brain over a period of time, over a number of years. This time may be out here to this point here, maybe as long as 10 or 15 years. The amyloid protein is slowly accumulating in the brain. And what we see is then subsequently the tau proteins are accumulating in the brain and causing injury to the nerve cells and loss of function of the nerve cells. As this is happening, the structure of the brain is changing in a subtle way, and we can measure that using MRI images. We can do MRI images at one point and then again in a year or two, and we can measure changes in the structures within the brain, particularly in the hippocampus, and we can look at the ventricular system, where we can see that there's shrinkage of the brain occurring. Normally, at age 65 and beyond, the brain shrinks at about 0.5% per year, but in people with Alzheimer's disease, it may be shrinking as much as 3 to 6% per year, so it's a magnitude greater. The next change that we see after the structural change is the cognitive change. So this is where we start to see people having the mild cognitive impairment and that impairment on the MoCA. The MoCA scores are starting to decline significantly, and then function is starting to decline. And this is where we cross that threshold to making that functional diagnosis of dementia. And in this instance, it would be dementia due to Alzheimer's disease because of the accumulation of the amyloid protein and subsequently the tau protein. Now, Alzheimer described this on an autopsy. So fortunately for us, we don't have to go that route, and we can do, unless there's a family history that we want to pursue. Certainly, we strongly encourage families, if they're interested in knowing what their family member died of, we can do autopsy examination. But here we can actually, in real life, determine if a person has amyloid in their brain. This is a normal PET scan. This is a positron emission tomography scan. This is a normal scan, and this is one showing the amyloid accumulation in the brain. And there's an obvious difference between these two scans. These are scans that are done at this site, at St. Joseph's, on our PET scanner here. We have a PET MRI scanner, and it's a combined PET and MRI scan. It's the only one in Canada, and we have one of the newest cyclotrons here. And so we make this compound, this tracer, to be able to make this amyloid scan. And this is what a scan would look like if we were to look at a combined amyloid and tau PET scan. So this again is a positron emission tomography scan, and we've got 4 different people here. They're 4 separate people, and the first 3 are all cognitively normal, and this person here has Alzheimer's disease. And so this person here has a little bit of amyloid accumulating in the brain. This is the A-beta amyloid protein, and this is the same person scanned at the same time with the tau PET scan showing the distribution. You can see the distributions are a bit different. They're not following exactly in the same place. And this is a person who's got more amyloid and more tau, and this is a person who's even got even more amyloid and more tau, and still they're cognitively intact. And part of the reason for this is that this person may have resilience to actually developing cognitive impairment. Part of it may be education. Maybe they're doing a lot of the right things to actually prevent the development of dementia. Eventually, however, those resilience may be overcome, and a person may progress to mild cognitive impairment and dementia. And you can see now, in this case, a person has a lot of tau protein here destroying the nerve cells in the entorhinal cortex. This is in the temporal lobe. There are other new developments that are happening in PET imaging here, and this is a new development using 18-FEPA, which is developed here by our neurochemists at this site in frontotemporal dementia. And my colleague over at Parkwood Hospital, Elizabeth Finger, is one of the cognitive neurologists involved in this research with her colleagues from this site. And this is a PET MRI scanner, and this looks at activated microglia in people who have frontotemporal dementia. And this is what the images look like. So this is Udana Anazoda, who is a PhD scientist working with Dr. Finger and the rest of the scientists here. And so you can see this is the PET the MRI image. So if we look at the normal image here, this is an image in this axis through the brain like this. This is the next one above it is one straight down through the brain. And then you can see in the image in the person with the frontotemporal dementia, the temporal lobes are severely diminished, and there's a lot of shrinkage here. If you compare this brain here with this one here, you can see there's a lot of shrinkage in the brain on the MRI. And then if you look at the FEPA scan, you can see the activated microglia being identified and compared to the control images here and here. So this is a test that could be used for diagnosis. It could be used for following a person if we had a treatment for frontotemporal dementia, and there are treatments now being tested as part of randomized controlled trials that might actually improve the situation for this person, and you might want to have a PET image to actually be able to follow that over time. There are some treatments for Alzheimer's disease which have been proven through randomized controlled trials over time, and I'm going to talk a little bit about them and then also where we're going in the future with some potentially disease-modifying treatments. So this is time over years. So this is the course of typically of progression of Alzheimer's disease from diagnosis through to a person being severely impaired. This is a scale here called the mini-mental state. It's different from the MoCA. It's also scored out of 30 as well, but it's the American scale. It's 5 cognitive domains. It's a shorter test. It's a bit easier, but it's used widely in clinical trials. So a person here has mild cognitive impairment and they may progress. This is that steep portion where families said the person's getting worse over time, and this is progressing through to severe dementia. We have treatments which 4 different drugs. You may be familiar with some of them, the cholinesterase inhibitors and the NMDA inhibitor. This is a course that a person who responds to that treatment might follow. Not everyone will respond to that treatment. Maybe about 35% of people will have a modest response. They're not going back to normal, but there may be some improvement over 6 months or a year. They may look more like themselves. They may have better memory, may have a little bit better of executive function, ability to plan things. However, we would like something that actually alters the course of the disease. And what we're looking for with the current treatments are disease-modifying treatments, one that might actually alter that course. So if a person over time ended up here as opposed to here or here, this would be a better place to be. This would be a person who's still in the community. They may not be driving, but they may not be in a nursing home. So the disease-modifying treatments, if we had a clinical trial, if we had a successful clinical trial, the people in the treatment arm would follow that line there, and the people in the placebo arm would follow that line there. And so that's what we're certainly looking for in our treatment trials. Now, this is a very complex disease, and I don't want to minimize the complexity of this disease. Some pharmaceutical companies have even pulled out of the search for trying to find a cure for this disease. However, there are strategies, and immunotherapy is one that has been pursued at present. Immunotherapy is being used in cancer treatments. It's being used for rheumatology and various rheumatic diseases. And so it's been used in Alzheimer's disease. Now, with immunotherapy, you might understand what active immunotherapy would be like. So this would be someone who had a vaccine. If you got a vaccine to a flu virus in the fall, you would develop antibodies. Your body would produce antibodies to that vaccine. That's active immunotherapy. And the immunotherapy, most of the treatment trials that we're pursuing involves passive immunotherapy. So we're going to give people in the trial either medication or the placebo, and the medication would be an antibody to amyloid. We're going to try and remove that amyloid from the brain to stop it from accumulating in the brain and stop it triggering more of that tau protein in the brain. There are also antibody treatments going after the tau protein to try and remove tau from the brain. And this passive immunotherapy is provided either as an antibody intravenously, or we can also give it as an injection under the skin. So this now is using PET scans in clinical trials. So to get into a clinical trial, now you actually have to have a positive PET scan. So the PET scans that I referred to earlier, these can't be ordered clinically. They cost about $5,000 each. They're available as part of a research protocol, and to go into a clinical trial, a person has to have a positive PET scan, because if you're going to try and remove amyloid from the brain, you want to know the amyloid is there. And so you see the sense in that. So some of the earlier trials, when we didn't have amyloid PET scans, and some of the reason they failed is because, in retrospect, when we then looked at some of the ones who actually did have some PET scans later on in the trial, 36% of the people in the treatment arm didn't have amyloid in their brain. So they couldn't possibly, although they had a clinical entity that looked like Alzheimer's disease, they couldn't have positively benefited from the treatment because they didn't have amyloid in their brain to remove it. So this is an advance. So this is something that we've learned from some of those negative trials that we've had. So this is the images here. These are PET scans at baseline and 1 year. So this is PET scans at 2 different time points, and these are the people in the placebo arm. So their scans look similar. But these are people who are on this drug, aducanumab, which is probably one of the leading drugs being developed in a phase 1 trial now being tested in a phase 3 trial, so we're waiting for the results of that. 3 milligrams, 6 milligrams, 10 milligrams per kilogram body weight is the dose given every month over a period of a year. And so you can see that the people that are on the treatment, there's less amyloid in their brain. And so this is another one. This is a complex side. I'm just going to explain it because this is the way they sort of analyze the data from the study. So this is time in weeks. So this is out to 54 weeks here. And this is the change from baseline. So everyone starts, it's adjusted to starting at the same baseline. And during the course of 26 weeks out to this point here, Some people are on the treatment, some people are on the placebo. So if we look at the placebo arm, this is the placebo arm, the grey arm here, and as we get up this scale, this is the baseline in terms of the clinical dementia rating scale. This is a measure of cognitive function and functional ability. It's a combined score, but it's a very robust measure that we use in clinical trials, and we can see that the score is actually increasing for the people on the placebo, but you can see with increasing doses of the medication that the score is actually coming down. Now, why doesn't it start immediately? Because it's a disease-modifying treatment. It takes a while to work. So you can start to see that at this level, we're starting to see a decline in the score from this point here at 6 months out to a year. This is a very important finding because this is the first time in a phase 1 trial we've actually seen an effect of the drug. We don't look for effect in phase 1 trials. We look for safety. So they found it was safe, but as well they saw that there was a dose effect, which is actually a very compelling finding for this particular compound. It's an exciting finding. We are doing other trials, and we're moving from the right, where we were doing a lot of trial in mild to moderate dementia, and the learnings we got from those trials are that this is almost too late to be doing the trials. And so a lot of the trials are moving into mild cognitive impairment. We have one particular project. It's a small project and it's a study involving jazzercise, postmenopausal women doing jazzercise as an exercise intervention, learning new exercise, and also socializing, so they're getting the mental stimulation, socialization, and learning while they're doing the exercise. And we're doing imaging with this study. So this is something that we're excited to see the outcome of this particular project. These two trials here are in people who are normal. So these are people who have one generation 2 is just one copy of E4, and generation is 2 copies of E4. So people who are 60 to 74 who have 1 or 2 copies of these genes can participate in these trials. Now, people won't know that, but they may have a strong family history, and if they have a strong family history of Alzheimer's disease, if they in that age group, they may want to inquire, would it be worthwhile doing this trial, because you would find out what your genotype is, and then you would get a PET scan, and if the PET scan was positive, you could participate in the trial. You could be randomized to be in the treatment, getting intravenous antibody every month for 3 years, and then continued treatment as part of an open label phase of the trial. So we're going to come to another poll. This is the second last poll, and what we want you to do is to reflect on everything that you're doing now, everything that you've learned, to see if there's anything that you would like to add to or improve to your current regimen. So you can choose here, so you want to open your apps and choose, are any of these things you want to add to your current regimen. So it's interesting, everyone feels that there's something else that they may want to do. And again, Mediterranean style diet, restorative sleep, exercise. So that's important. One of the last things I want to talk about is why would people even want to go into a randomized controlled trial? You're randomized to be in the placebo arm, nothing, versus treatment. And there are 6 different reasons that we consider people may want to think about going into a randomized controlled trial. The placebo effect, it has a positive effect. People who are on a placebo think they may be on a placebo, it has a positive effect. During the course of the study, you get close medical monitoring. You'll be seen monthly by the coordinator, and usually every 3 months by the investigator, or at any other time that there's any blood work abnormalities, that's sent to your family doctor. Even if it's nothing to do with the clinical trial, your family doctor will get a report. You get some additional stimulation and interaction with another group of people. You expand your circle. The people that participate in the trials develop a really important relationship with the coordinators. If over the course of the trial we see that a person is progressing, they can be referred to the community resources. So rather than waiting for the time that it comes to follow up, in my clinic right now is 2.5 years. I see people after the initial assessment 2.5 years later. They can be seen sooner, and referred to those resources if they're not already in contact. So that might be the Alzheimer's Society or day programs or respite for caregivers. And then continued access to the medication. So if you're in a clinical trial, you've participated in the trial, after the trial is completed at that 3-year point, there's an open label phase where everyone, 100% of people, go on the trial. That's what we mean by an open label phase. So then you can get access to the medication, waiting to see if it's effective, waiting to see the outcome of the trial. Whereas people who have not participated in the trial can't get access to that medication because it's not yet approved. And then altruism is the most compelling reason for a lot of people. They say, I am on medications now. I'm benefiting from someone else's altruism who went ahead of me and proved that the treatments that I'm on are safe and they're effective for me to take. I have benefited from their altruism. And here I can give back to other people, and someone else, it may not be me, may benefit. It may be my friend, it may be my neighbor, it could be a family member that would know. So that would be an additional reason. So we'll come to the last question. If you were eligible to participate in a clinical trial or a research study, how likely would you be to participate? And so you just choose one answer. You have to open up your app and okay, so that's nice to hear. There's certainly support for people interested in research, and we certainly would encourage you. There's lots of observational studies that we have, even for people in normal older controls. Many of you here who fall in that normal category can participate in normal observational studies. If you fall in that older age group, there's that Generation 1 and Generation 2 study. So if you plan on getting old, be careful what you plan for. There are 6 non-drug approaches we've talked about tonight to reduce your risk. And then we're going to talk about the control of, to prevent the 5 vascular risk factors. What are they? Blood pressure, diabetes, cholesterol, atrial fibrillation, smoking. Good. So consider how you can support research for the future and really understand how we can improve our understanding of dementia and try to strive and maintain your brain. Now, there's one thing that won't have been lost on some of you. There was a really important day on Saturday. Does anyone remember what was important on Saturday? It was the World Chocolate Day. That's true. So when you leave, we have in honor of World Chocolate Day, belatedly, you may help yourself to a chocolate. Dana has brought the chocolates. I can see there's some takers. Now the caution, this is dark chocolate. It has to be at least 70% chocolate, and anyone who has antibodies or allergies to chocolate, I would ask you to abstain. Won't be, okay. So I do need to thank people who have helped me tonight. Now this is my memory test. Matthew, Warren, Craig, Renee, Dana, who's helped here with this. Dana happens to be working at Parkwood Hospital with an important project, but she also happens to be my daughter, so she keeps me in line. And the other person who also keeps me in line, more than Dana, is my lovely spouse, Nancy, who's here in the front row. She's my queen of the Mediterranean-style diet. We had Mediterranean-style diet tonight, and I didn't even have to prompt her tonight. We had that before we came. So that was lovely. So these are my other colleagues that we work with, Jenny Wells, Elizabeth Finger, Stephen Pasternak, research managers. There's a number there if you want to call and participate in research. All of our coordinators, our nurse practitioners, our nurse clinicians, our research assistants, our trainees. Dr. Jennifer Fogarty, who's a neuropsychologist who does an important job in doing more detailed neuropsychological tests in people who we have very difficult time diagnosing dementia, so we need to do a deep dive. And then our colleagues, Joe Lindsay, medical informatics, and our group across the city, Frank Prado, who leads the group here on neuroimaging, the PET imaging, Dr. Manuel Montero Dasso, and the group across at mental health with Ama Burhan, and Rob Bartha is at the Robots Research Institute. So we are going to have questions, and I should have said this earlier on, there is the opportunity to open the app and ask questions, and you can put in the questions there, and I'll be able to read some of them off the screen. Now, if you like a question, you can like it, and that can actually influence, it can influence the position of the ranking of the questions as well. For those of you who have decided that you would prefer to ask a question, put your hand up and call out the question, and I'll identify you, and I may have to repeat the question. This gentleman here, would you like to ask a question?
How do you interact with Robarts Research?
How do I interact?
Yeah.
How is our group's interaction with Robots Research Institute? It's an important way in which we interact with them, and that's with their neuroimaging group, Dr. Rob Bartha, who I met there, and they are involved with the MRI scanners. They have 2 3 Tesla MRI scanners. They also have the only 7 Tesla scanner in the country. And this is a very powerful MRI scanner. And this is one that people can come and have a scan as part of a research study. We have a young MD, PhD graduate study who's doing an MRI study with them. We also look at the effect of drugs and measuring. We've done studies which we've published looking at drugs before and after, before they go on the drug and after they go on the drugs, particularly the Alzheimer drugs, the ones that are in practice now, standard practice. We've published all of that data. So they measure different types of images in the brain. They can measure chemicals in the brain. They can measure up to 19 different chemicals in the brain using a particular approach called MR spectroscopy. So there's a lot of very interesting data that we can get from MRI scans. They also are also providing all of the imaging for our observational studies with the ADNI study, the Alzheimer's Disease Neuroimaging Initiative, which is an international study between the US and Canada, and also a Canadian initiative, which we in London are taking the initiative on. We've got 1,600 people from across Canada participating, and our site here in London is the most active site in that, and all of the neuroimaging for that study is done through robots. So thank you for that. So we'll look at some of the questions here. So what are some of the early signs of dementia that I might be able to detect in a friend or a family member? So this is a very important question to ask, and it's an important question to be insightful about. So when we talked about subjective cognitive decline, the person who has subjective decline, only they may know that they actually are experiencing the symptoms, particularly if they're in the workforce. They may be aware that they're not quite as sharp as they used to be. They may have difficulty putting their finger on it. They may have difficulty remembering certain procedures that they do. They may have difficulty with certain applications on a computer. No one else would necessarily be aware of that. At home, the family member, the spouse, may say, "We don't see any change." However, beyond subjective cognitive decline as it progresses, and so firstly, if a person says, "I have concerns about my memory and it's changing," it's very important that that's taken seriously. Too often in the past, and some people, some family members, or even family physicians may say, "Don't worry, dear, you're just getting old." And that's not an acceptable explanation. It does need to be taken seriously. So you need to make the observations and record it. And if you start to see changes in memory, so conversations being repeated. So if you have a conversation with someone and then they discuss the conversation again, and you say, "Well, we just talked about that yesterday." So, or we talked about that last week and they've forgotten that conversation. The frequency with which, or the interval of memory loss decreases. So sometimes it'll get to a point where in a telephone conversation, you may actually have them repeating the same information twice in the same telephone conversation. That's a very important concern. So I've highlighted memory there as one early sign. There are other signs, and with the Alzheimer's Society, you can go onto their website, and they have all of the different signs, early signs that you can look at, so that's a resource you can look at. The other thing to look at is language. So not everything it changes is memory, it can be language. So people's language can change, the way in which they use words. They may have word finding difficulties, they may say nonsense words, or they may rhyme a word, or they may substitute a word, or they may say, you know that thing, and they wait for you to fill in and say. Sometimes if you're that impatient person, you'll fill in it without even knowing you're doing it, and then someone else in the family will say, you're speaking for them, you know, you're filling in for them. And so it will become evident. Other early changes with frontotemporal dementia, a common feature of that disease might be a changes in behavior. So abnormal behaviors, so disinhibited behaviors, inappropriate comments in certain social settings, sexually inappropriate comments, behaviors that are not socially acceptable, or there may be apathy, there may be loss of engagement in a particular environment. Family come to visit and they're not even engaged with those family members. Now, some families that may be normal, but this is where there's a change in behavior we're looking. All families, by the way, are dysfunctional. So, okay. So the question about family history, how strong? So if you have a parent, one parent, and the problem began in their late 80s, you can anticipate that they might have problems in their 80s just from 80s or 90s. So people who have problems in their 80s and 90s, you might expect that. It's when family members have problems beginning in their 50s or in their 60s, much earlier, and particularly if they don't have some of those other risk factors, like the vascular risk factors, so they haven't had strokes, they don't have diabetes, they don't have high blood pressure, they haven't had elevated cholesterol. So if there are no vascular risk factors, one family member, a parent, would be important. If that parent had siblings, that increases the risk. So it becomes an integral, and then you can go back through your family histories. We don't have the large generations that we used to have, but you used to be able to go back. Sometimes we go back and you can see aunts and then you can see cousins. And with some of these diseases, particularly in the frontotemporal dementia, you can see family histories which go out into other generations. So I think you need to have a strong index suspicion if it's occurring at a younger age and if there's not another obvious cause. One thing we talked about, head injuries. So people who have had recurrent head injuries, we're hearing more about this traumatic encephalopathy, chronic traumatic encephalopathy, people with sports injuries. That is a head injury is a concern. The other thing that we haven't heard about a lot and hasn't turned up is there's the question there, the association with head injury. So I mentioned there the chronic brain encephalopathy. This is the people who have had recurrent head injuries. So if you take a soccer team, and that's particularly topical this week, you see those people out there heading the balls. The people that head the balls frequently have a higher likelihood of developing dementia later in life. So this is recurrent head injuries to the ball. We know that. We certainly see that in football players and in hockey players who have had head injuries. So it's a bad thing to actually have head injury. And if a young person has had injuries and had one or two head injuries, you need to seriously have the conversation with them. Do they really want to continue that sport? Is it really important that they continue to do that? Because further head injuries, the next time they had a head injury, often it's only a fairly minor head injury, but they get major symptoms. And then eventually you'll start to see the cognitive decline. So I think there is a very definite connection with head injury. The other one that I think is not spoken about is abuse. Different types of abuse, childhood abuse, sexual abuse. This is something that we're only just starting to become aware of, but people who have been abused as children, they have smaller hippocampi, smaller memory departments than people who haven't suffered from disease. And this is on MRI images. So we need to pay more attention to that. Often with abuse, people don't talk about it. Sometimes we don't even hear about abuse until they come to the clinic and they're starting to develop dementia and they're starting to become a bit disinhibited, and they're now willing to talk about the thing that they could never talk about in their 40s and 50s. They've never revealed it. I've had a spouse in a clinic revealed to me that she was abused before her marriage by another family member, and never discussed this with her husband. And that was a very poignant moment for her. We discussed it eventually with her. She wanted to discuss it with her husband. But sometimes this won't even come out until later on. There are some other questions here. Okay, so best practices for mental stimulation. I think this is something that is an evolving field. There are some interesting researchers that are looking at this, and I think one can look at the finger study, look at the different types of the mental stimulation. Watching television is not considered being mental stimulation. It's not an excuse to sit there for Saturday afternoon. It's new and interesting. So Sylvie Billville, who is one of our researchers as part of the Canadian Collaboration on Neurodegeneration and Aging, is looking at different types of mental stimulation. And she's looking at studies where she has people randomized to either learning another language, they can't speak it already, but they learn Spanish, or they will learn a musical instrument. They'll learn how to play the piano. And so this is a type of mental stimulation that she's exploring. There's another, Nicole Anderson is also participating in that. She's at the Baycrest. She's another one of the 400 odd, they're not odd, but they're 400 plus researchers across the country who are looking at dementia research. But she is at the Baycrest Center, and she's looking at mental stimulation as an intervention. So they're actually evaluating this. How much mental stimulation, what type of mental stimulation, are some of the questions that we actually have to try and sort out. How long? Some of the mental stimulation is through computer games, computer tests. Up to now, they haven't really been shown that they're good at improving your mental function in other areas. They make you better at doing those particular tests, but it doesn't help you with other activities. But I think this is a new and innovative area that we're continuing to explore. So I think read the literature and see what starts to come out. The important thing is it shouldn't be frustrating, and it should be new and innovating, because what you're trying to do is to get nerve cells that are not talking to each other. And if you think about the billions of nerve cells that you still have in your brain, and if you look at one nerve cell, on that nerve cell there will be up to 2,000 synapses. What you're trying to do is to get some of those nerve cells to build new connections, new synapses, in a new and interesting way, to build in some of the resilience. So this is building on neuroplasticity, and even as we get older we can continue to do that. We certainly see that in the rehabilitation and people that come to rehab at Parkwood, say people who've had stroke and they rehabilitate. Part of this is building on that neuroplasticity, and this is what we believe is important in people who have neurodegenerative diseases, to try and alter the course of the disease. It said here, is it possible to reduce amyloid and tau in the brain without using medications? It's conceivable, and I think one of the things that we want to be able to do is, now that we have neuroimaging and PET scans, I think there will be research that will look and try and answer some of these questions. So the PET amyloid imaging we've only had since 2004. The tau imaging we've only had since 2014. And we don't know yet which is more important. Is it more important to reduce the amount of amyloid, or is it more important to reduce that tau protein neurodegeneration that's occurring and killing the nerve cells? So would a strategy like exercise actually reduce those things? So if you had a longitudinal study and could do PET scans at the beginning and at the end, and have two groups, compare those who do exercise on a regular basis and the other group that do stretching and toning, is there a difference in the amount of amyloid that accumulates in the brain over a year or 2 years? Is there a difference in the tau accumulation? These are some of the questions that we could ask. So I think we could certainly explore what is the role of exercise, what is the role of other non-drug approaches. So we do have some, those would be just an example of some of the tools that we could have. Is there research exploring the relationship between dementia and a plant-based vegan diet? there certainly would be research there. I can't, we're not involved with it right now, but I think these are important questions to be asking. One thing we need to be doing is moving towards plant-based diets. I think that's what the Mediterranean-style diet and other diets, I've chosen to present Mediterranean-style diet information here, but there are other diets being explored. They don't have the numbers yet, but we do need to be moving towards plant-based diets, not just because of dementia. We need to do that for the survival of our planet. We have to move away from meat as a source of protein and engage other vegetable sources of protein. So I think these are things that will be being explored, but I can't speak specifically to that. So excessive alcohol intake, what role does it have in the development of dementia? So one of the questions you have to ask yourself is, what is excessive alcohol intake? Excessive alcohol intake is someone who drinks more than their doctor. Now, I don't drink too much. My daughter can vouch for that. But I think you're not usually going to ask your doctor how much they drink. But I think there are important studies. Alcohol, even, you know, that Mediterranean-style diet, there used to be a bottle of wine on that slide, and we've taken it out. Because we know now that 100 grams of alcohol per week is about the most that anyone should be drinking. So that's only about 6 drinks a week. Yet the recommendations in the States right now is twice that amount as an allowable amount. But 6 drinks a week would be the maximum that a person should be drinking, standard drinks a week. Above that, there's increased death is much more likely. There's a higher occurrence of death or higher probability of death. But alcohol-related dementia is something that is grossly underestimated. I think that's something that we really don't have a really good handle on. And when we see people in the clinic who are doing any amount of drinking and they have cognitive impairment, we say, there's a choice here. You've had a good trot. You've been drinking for a while, and this is a trade-off between maintaining your brain, maintaining your independence, maintaining your opportunity to be engaged in the community, or progressive dementia and ending up in a long-term care home or worse. And most people are persuaded by that because they want to hold on to their independence. That's what they're really striving for, and they will listen to that. And most of them will say, you know, I don't really enjoy it. It's just a habit. My wife and I sit down and we have a drink together, and it's something we've always done. It doesn't have to be alcohol. And in this hot weather, drinking a non-alcohol beer is nice. Why do you suspect there is an increased concentration of microglia? So this is an important question. I'm not involved with this research directly, but we do know that within dementia there are inflammatory processes, whether it's with Alzheimer's disease or whether it's in frontotemporal dementia. And what these test, the FEPA, is actually getting in the activation of microglia. It's part of the underlying disease process. Why that inflammatory process is occurring, we don't entirely know. But I think it's important that we can actually measure it. There were some longitudinal studies of anti-inflammatory medications looking at people who are on anti-inflammatory medications for rheumatoid arthritis, and people who are on long-term anti-inflammatory medications like the non-steroidal anti-inflammatories. They had less risk of developing dementia, less risk of Alzheimer's disease. So inflammation is part of this. So when I have talked to you about amyloid and tau protein, this is not the whole answer, and this in a sense is a simplified way of looking at this. It is a very complex disease. There are inflammatory processes going on. There's a lot there that we still need to understand. And each time we do these clinical trials, even if it's a negative trials, the analysis of that data helps us better understand what is the underlying model. So I'll do one more question, maybe here for this lady.
You mentioned earlier Down syndrome.
Thank you for that question, yes. So Down syndrome, so what is it, why do people with Down syndrome at risk of Alzheimer's disease? Now they're different from older individuals who accumulate amyloid in their brain because they can't get rid of it. But people with Down syndrome have a trisomy on chromosome 21. So on chromosome 21, instead of having 2 short arms, they have 3 short arms. And on that short arm on chromosome 21 is the amyloid precursor protein. The amyloid precursor protein is encoded on that short arm. So instead of having 2 copies, they've got 50% more. So they make more amyloid. So this is a model of dementia and Alzheimer's disease. So we know the connection here is with amyloid. These people make too much amyloid protein. So one could say if there was a way of removing amyloid from the brain, reducing or somehow inhibiting the expression of that amyloid at a genetic level, that might reduce the likelihood of them developing Alzheimer's disease in their 40s or their 50s or the 60s, because that's when it happens. They start to develop cognitive impairment, and you can't test them. Some of them you can. Certainly we've had people with Down syndrome have come to the clinic and they can do well cognitively on, say, a mini-mental state exam. Some of them haven't developed as well intellectually, and so we use functional scales. But the routines that they used to be able to do, the things that they were doing in their workshops, these routines are starting to be abandoned, and there'll be behavioral changes coming up. And this is how their dementia expresses. So thank you for coming back to that question. Okay, I'm going to stop it now. Please remember to take your chocolate at the home. Otherwise, I'm going to be forced to eat it, and I know I'll have a couple of people to help me. Thanks very much.